Hello everyone, and welcome back to our channel. In our previous video, we covered an overview of history taking. Today, we'll be discussing the format of history writing, breaking down each component and the key questions you should ask to gather a complete and effective patient history. By the end of this video, you'll know what to ask your patient, how to collect the right information, and how that information will help you both at the bedside and during your clinical exams. Before we dive into today's lesson, if you're new here, don't forget to like this video, subscribe to the channel, and share it with your fellow med students. Alright, let's dive in. History writing consists of several important components. The major, or most commonly included, components are patient identification, previous admissions, chief complaint, history of present illness (HPI), past medical and surgical history, personal, social, and family history, review of systems. In addition to these standard components, we often need to include department-specific details depending on the clinical setting. For example, in pediatrics, we should also include immunization history, developmental history, nutritional and birth history. These help us gather more accurate and relevant information about pediatric patients. Similarly, in the obstetric ward, there are specific elements we must add under the history of present illness, such as gravida and parity, last menstrual period, LMP, expected date of delivery (EDD), and other pregnancy-related details. Customizing the history format according to the department ensures that we collect complete, focused, and clinically useful information. For today's video, we're going to focus only on the standard or common components of history taking. We'll cover the department-specific additions in future videos. Alright, let's begin with the first component, identification of the patient. This is the first part of history taking. It helps us distinguish one patient from another and gives us context that can guide both diagnosis and management. Let's go through each element one by one. Name. This is used to identify the patient and distinguish them from others. Age. Age is important because many diseases are age-specific. For example, children, adults, and the elderly are prone to different illnesses. Sex. Knowing the patient's sex helps us narrow down diagnoses based on sex-specific conditions. Occupation. The patient's occupation can give us clues about possible exposures to certain risks, such as chemicals, dust, or physical strain, which may be related to their current illness. Address. This has two main uses. One, epidemiological relevance. Some diseases are more prevalent in certain areas. Knowing where the patient lives can help narrow your differential diagnoses. 2, planning for care. It also helps us determine how easily the patient can access the hospital for follow-up or ongoing care. Okay, another identification part is religion. Religion can impact both diagnosis and management. For example, Jehovah's Witnesses may refuse blood transfusions and organ transplants. Some patients may be fasting, which can affect test results and treatment schedules. Always respect and consider these factors in your care plan. Next, ethnicity or race. Some diseases are more common in specific racial or ethnic groups. For example, sickle cell anemia is more prevalent in people of African descent. This information can guide diagnostic thinking. Next one is hospital details. Include the name of the hospital, ward, room number, and bed number. This helps in locating and identifying the patient accurately for documentation, follow-up, and team communication. Another identification part is mode of arrival. This has two parts. First, how the patient arrived at the hospital gate. Was it by walking, public transport, ambulance, etc.? Then, how the patient was transferred to the ward. Were they walking in a wheelchair, on a stretcher, carried by someone, or supported? These details can reflect the severity of the patient's condition upon arrival. Next, you should include source of history. This refers to who is providing the information. the patient themselves, a relative or caregiver, a medical record or referral letter. Mentioning this is important because it tells us how reliable the history might be. The final identification part is source of referral. If the patient was referred from another facility, include where they came from, when they were admitted there and for how long, what diagnoses were made, what treatment they received, and the reason for referral to your hospital. For example, is it for better investigation, management, or both? All of this information under identification sets the foundation for accurate and effective patient care. Okay, the next component of history is previous admissions. In this section, we ask whether the patient has ever been admitted to a health facility before the current admission. It's important to understand what we mean by admission. An admission refers to a situation where a patient stays in a health facility for more than 24 hours, usually in a hospital bed, for observation, treatment, or further evaluation. Simply visiting a hospital for a quick checkup or treatment and then going home does not count as an admission. So, if the patient has a history of previous admission, we should gather the following details. When was the patient admitted? We should record the exact year, month, and the date of admission as well as how long the patient stayed in the hospital. Where was the admission? Which hospital or health facility? Why was the patient admitted? What were the initial complaints or symptoms? What diagnosis was made at that time? What treatment or management was provided during that admission? What was the outcome of that treatment? Was the patient discharged with improvement, referred elsewhere, or did their condition worsen? This helps assess the effectiveness of the previous care. Collecting this information helps us understand if there is any connection between the previous illness and the current problem. It also helps us assess whether the past treatment was effective or if the issue is recurring or worsening. If the previous admission is directly related to the patient's current complaint, this connection should also be documented in the History of Present Illness, HPI section. It provides continuity and helps us better understand the clinical progression of the illness. Alright, let's come to the third component, chief complaint. The chief complaint is the main reason the patient has come to seek medical attention. It reflects what the patient feels is most urgent or troubling. In this section, we should always include two key elements. 1, the symptom. 2, the duration of that symptom. For example, if the patient says they came because of a cough, we should ask how long they've had it. So we would document it as cough of 1 week duration or cough of 2 weeks duration, depending on what the patient tells us. And also based on different types of symptoms we can add the localization of the symptom, where exactly is it felt. For example, we can say right side abdominal pain of 3 hours duration. The progression of the symptom, has it worsened, improved, or remained the same since it started? For example, we can say exacerbation of cough of 1 week duration. Sometimes the patient may report more than one symptom. In such cases, we can list up to 2 major symptoms along with their durations in the chief complaints section. For instance, cough of 1 week duration and fever of 3 days duration. This part should be written briefly, clearly, and in the patient's own words as much as possible. It gives us the starting point for further exploration in the next part, the history of present illness. Okay, before we go to the next part, I would like to appreciate you to hit that like button and subscribe to the channel. It means the world to us.